Oppositional Defiant Disorder, Lytisha, Florence. The DSM-5 definition of oppositional defiant disorder has three criterions. The first one is a pattern of Criterion A is a pattern of angry or irritable mood on most days during a 6-month period. This includes a child losing his temper very easily. They're easily annoyed, usually angry or resentful. Criterion B are the classic signs of oppositional defiant disorder. Their behavior is argumentative or defiant, which includes arguing with authority figures, defying and refusing to comply with adult requests, and will intentionally annoy others. They will also blame others for their behaviors and their choices. Criterion C is vindictiveness. This criteria is what makes it different from most other diagnoses that could explain angry or irritable behavior. In vindictiveness, the child must be spiteful or vindictive at least twice in a 6-month period. Severity is deemed mild if the symptoms only occur in one setting, such as the home only. Moderate symptoms if the symptoms occur in 2 settings. Severe if the symptoms persist in 3 or more settings. ODD is more common among males, in particular in homes where there is another sibling. Because ODD symptoms are displayed in familiar settings, symptoms may not be apparent in a clinical setting where a diagnosis may take place. ODD is also prevalent in children with transient caregivers, such as foster children or those being raised by multiple caregivers. There are no racial markers to determine if one racial group is more predisposed to ODD. However, home environments in impoverished neighborhoods with high crime rates have been linked as a causal factor of ODD. In regards to Latinos and their feelings regarding this diagnosis, Latinos place high value on respeto, in which children are expected to obey their parents and other adult figures. Disrespect or disobedience of parents or other adults is considered to have a negative effect on the family as a whole. Thus, it is very, very much not tolerated. ODD, what it is not. It is not normal childhood behavior consistent with age and development, such as a 2-year-old having a temper tantrum. It is also not ADHD or attention deficit hyperactivity disorder. Caution should be exercised in diagnosing ODD at a young age. It should also be distinguished from disruptive behavior resulting from inattention and impulsivity associated with ADHD. A child should not be diagnosed as ADD when a behavior is a protective factor due to living environment or high crime community. It should be distinguished from failure to follow directions due to a language barrier or due to hearing loss or a learning disability. It is also not a depressive or bipolar disorder, which are very similar and often involve negative affect or irritability. It's also not disruptive mood disorder, where the severity, frequency, and chronicity of the temper outbursts are more severe. It is intermittent explosive disorder is also another disorder with high rates of anger, showing serious aggression toward others. In regards to conduct order disorder is a more severe form of behavioral issues involving anger and irritability. If a child has a diagnosis of conduct disorder and there's suspicion of oppositional defiant disorder, only one diagnosis can be assigned to a child. You cannot have a dual diagnosis of ODD and conduct disorder. If the behaviors are severe, then conduct disorder will be assigned to the child for the behavior. Contributing factors of oppositional defiant disorder include biological influences, environmental features, and family functioning. In the biological influences, this may include genetics or heritability, in which other family members may have been diagnosed with mental illness. It's also important that some relatives have gone undiagnosed but have suspicion of mental illness. A mother who smokes while pregnant is also a biological influence of oppositional defiant disorder, as well as injuries to the brain or trauma to the brain in infancy. Environmental features such as dysfunctional family life, family history of mental illness, or substance abuse also play a role in the environmental features that affect or cause oppositional defiant disorder. Family functioning include the parental conflict, which may involve discord, separation, or divorce, poor parent-child attachment, abusive parents with histories of antisocial behaviors, parental rejection of a child, lack of supervision, lack of involvement in a child's activities, inconsistent use of discipline, ineffective parenting, and living in a high crime-infested neighborhood. Evidence-based training to initiate change include individual therapy, parent training, in-home behavior therapy, social skills training, social behavior plans. So in the individual therapy is designed to help children to learn to manage their feelings in a positive manner. In the social skills training group, they learn positive interaction with their peers and prevents them from feeling isolated or feeling rejected by their peers. In-home behavior therapy includes services that will be provided both to the child and the parents inside of the home. School behavior plans includes in-school behavior management plans, which allows the child to have some input, concrete choices and consequences, and medication may be an option as well. Finally, parent training, which is considered the most consistent and most positive and less frustrating, helps a parent to rephrase or retrain the parent on their particular parenting style, which will be most effective for a child suffering from oppositional defiant disorder. Psychopharmacological treatments. According to the Mayo Clinic, there are no medications approved to treat oppositional defiant disorder specifically. However, low doses of atypical neuroleptics have shown improvements in behaviors. These neuroleptics include Risperdal and Abilify, which are traditionally used for patients of ADHD. In my research of oppositional defiant disorder, I was surprised that there was not as much recent information or research on the study. Some of my studies dated back to as far back as 1985, 1995. The most recent data that I found was 2010. There may have been more, but in my research, that's what I found. The latest was 2010, which is surprising. I did also read in the DSM-5 that there was some speculation whether or not oppositional defiant disorder needed to be removed from the DSM-5 as a category, and should it be just included with conduct disorder. I think what's important to remember is that ODD does not make a child bad. There are certain circumstances that cause a child to have this particular disorder, again, including biological features, environmental features, and it could just be poor parenting or just, the situation in which the child has grown up in. What would be important for parents and for teachers is to remember that the child is not the behavior and that the child can change that behavior once clear instructions and understanding of developing social skills and problem solving, so that they are not as frustrated and taking their frustration out on others. Thank you.